Great. Okay, welcome everybody. Sue Grinnell here. I'm excited for today. We are going to have a discussion about community engagement, and hopefully you all had a chance to watch the video prior to this. And then today we're going to hear from Dr. Mo Sammy. She's at UC Irvine, and I'm really, really excited about this discussion. Just a little bit about her, about Dr. Mo, we'll call her, has worked on socially and environmentally sustainable planning, public policy, and research in partnership with both community and intergovernmental organizations for over 20 years. So she's down at UC Irvine, so down in Southern California, where it's apparently raining very hard today. So I'm going to turn this over to Mo to get us going.
Well, thank you. It's such a wonderful honor to be with all of you today. Thanks to Sue for inviting me and having me join you. I'm so excited to see what you thought of the video. Before we actually engage in those conversations, I thought we'd do a quick review of kind of like the goals of today's webinar. And then I wanted to touch base on some of the assumptions that I make in community engagement. And from a health perspective, it lies in the importance of the social determinants of health, why they matter, especially why they matter to communities. And then we'll do our little discussion of weight of a nation. Just so that I can see your hands with thumbs up or thumbs down, what do you guys think of that video that you had to watch, the documentary? Good. Oh, I'm so glad. Oh, good. I'm not getting any of these, so that's good. And then we'll do some Q&A and wrap up, if that's okay with everyone. Is that okay?
Yep, that's great.
Excellent. So as you know, we're going to focus on a case study from Santa Ana in California that I know Dr. America Bracho, actually, and she's just as wonderful and feisty as you saw her on the video in real life, and with Latino Health Access. So I'm so excited that we can share some of the learning that we've had here in Orange County with the nation, it seems. So I'm so glad you got to watch it on your own. And then what we'll do is reflect on some of the principles that came out from your reflection of the video. And again, before we do that, I'm going to talk a little bit about some of the assumptions that I'm making before we actually engage in the conversation of community engagement. So I'm going to do a little quiz. I'm a professor. What are you going to do? Asking you the question, which one of these, A, B, C, D, or E, do you think has the most impact on population health? A, educating people about health. B, health care access, like doctors' insurance. C, where we live, commute, and work. Or D, socioeconomic status, which would include things like educational subsidies and nutritional support programs. So A, B, C, D, or E, A, and B together.
Do you want it in the chat box?
Oh, that would be fun. I don't know if I can see that, but yeah, let's do that. How do I see it?
Well, I can also help with that because you're doing this. So let's see.
Oh, there it is. So Sue, you tell me what the
I'll help you out there, Mo. So we have Nick saying C, Flathead C. Let's see, Alexa, New Mexico C.
You guys are using deduction skills very well. Bravo. Bravo. Okay, so I'm going to give you the answer. The answer is actually D, according to the CDC. Things such as educational subsidies, nutritional support programs for low-income mothers, for example, have the most impact on population health outcomes. But the second, it's very close, it's like within 2 points of one another, was where we live, commute, and work, or what are collectively C and D actually are known as the social determinants of health. The least impactful is A, educating people about health, which sometimes I feel becomes the bread and butter of public health agencies, is the education component for individual behavior change. But according to the CDC and actually WHO, in their 2007 seminal report, Closing the Gap in a Generation, making progress on on health equity through the focus of social determinants of health, we realize that C and D, the places where we live, work, commute, study, pray, and the socioeconomic status, the programs intended to improve household access are the most impactful for community health outcomes. This is all based on the social ecological model of public health, which I tend to call the social determinants of health. You've all seen this by Dahlgren and Whitehead from 1991. And again, because we in public health are so good at working on those individual lifestyle factors, we tend to focus there and not really reach out and think about agriculture and food production, education, work environment, water and sanitation, transportation systems, sociocultural determinants of health. Those seem to be so big that we rarely get an opportunity to engage at that level. And I want to impress upon us how important it is for us to look at this model. Another way to think of this model is to think, how do I put health in all of these policy frameworks? How do I put health in all policies, essentially, and programs? The reason why this is important, because when we address the environment, we're actually creating a process where we make the opportunity for success of our individual health education programs more impactful. So for example, the upper left picture is a picture from Oklahoma that was sent in by a community resident who had just heard of the specific health department in her county was encouraging residents to walk more. And the resident sent this picture in and said, how do we walk more if our sidewalks end nowhere and we don't have access to places to walk safely, to be able to be active safely outdoors? This is one of the reasons why I say, first, thinking about the social environmental determinants of health, and second, really listening to the community before we make our health programs and opportunities and marketing campaigns to walk more and eat healthy, for example. We have to think about in what context are those decisions being made. So that's one. Another example could be, for instance, if a community only has open spaces for play and recreation in their school year because the school grounds are open. But once the school year closes, summertime, it closes, the community loses access to all of their green spaces and playgrounds. We see a lot of this in South Central Los Angeles, for example, or in urbanized communities that only have that small space of play for their children. So what happens in the summer when children and communities don't have safe spaces to play outside? There's ways that we can address this, but again, we won't know unless we're actually thinking about health in a broader context. The one on the bottom left shows you a picture of a pizza and our wonderful little food pyramid. Why do you think I have this picture up? Any ideas? I see everybody's awake. Bravo. So the reason why I put this picture up is because in public health, we're not always trained to take lobbyists or private sector to account for the impacts they make on human health. So the tomato lobby was very successful in advocating to federal food policy to make pizza recognized as a vegetable in school lunches. So if we just look at data, what our schools are feeding children, because they're allowed to say a vegetable is a serving of a pizza is a serving of vegetables, if we're just looking at the data without actually going and seeing what the children are eating, we might mistakenly assume that the children are eating vegetables. Whereas in fact, they're not eating a vegetable, they're eating pizza. And as delicious as pizza is, making me hungry around lunchtime, it doesn't help us to understand the actual choices that the children are making if we don't go into the community and actually see, or if we don't engage with the school board or the school lunch folks that are actually creating these opportunities for our kids. The one on the bottom right is an actual picture of a drive-through liquor store.
Where is that?
I don't want to say because I don't want to stigmatize this poor community. But just thinking about all of the efforts that we put in public health, for example, to curb drinking and driving, what would you do in this community that has access to, by the way, 24-hour drive-through liquor service? So it's like there are ways that the environment that we live in actually impact our individual choices beyond our capacity to make a choice. Does that make sense? So it's like if we're walking in on a sidewalk to nowhere, how can we ensure that we provide the opportunity for our residents to be more active, for example? So in other words, thinking about risks, exposures, and outcomes in a broader way helps us really understand what communities are dealing with. They're not just experiencing individual health behavior risks. Health is not just an outcome of individual responsibility, but really thinking about all those things that impact the household. Is there adequate housing? Is there adequate income for a sustainable livelihood? Is there presence of domestic violence? Are there social and political risks? I put policy frameworks here. For example, the policy that allows a drive-through liquor store. And then thinking about concepts in different communities such as racism. We here in California with the California Endowment has actually been encouraging us to think about cultural healing paradigms for our Native American communities. And what we've noticed through engaging with our community partners, for example, there's a program called La Cultura Cura, which means the culture of healing, but also culture heals. And in Native American communities, what we've noticed is connecting the young people to their roots, to their cultural roots, whether it's linguistic or through food and cultural practices, elevates their health outcomes. We would never have thought about that unless we had gone into the communities and spoken to people about their needs, their cultural framework. So I would say thinking about what are those social and political risks that we can address. Which communities can we partner with, which organizations? And then obviously thinking about those environmental risks, the built environment being one of the most important ones. Air pollution, now we know, is one of the top 10 causes of disease and injury in the world. So how do we address that if we have communities or neighborhoods that are living close to industrial zones? How do we address that? Or living close to freight transit corridors? How do we address those things? And I think the broader we think about public health and health outcomes, the more likely we are to catch those social ecological determinants of health. And the closer we connect to our communities in person, on the ground, face-to-face engagement, the easier it will be for us to understand all of those, for us to understand the context in which they're making those health choices. So I wanted to do that as by way of introduction, some of the assumptions that I'm making for community engagement in this context before we launch into this discussion that I wanted to be the heart of this particular webinar. So I wanted to shift, if that's okay with you all, unless anybody has any questions. Going once. Okay. So I'm wondering if we could go site by site perhaps and share some of your reflections. Maybe we'll start with the first question from your epidemiological data or your community needs assessments, thinking about what are the top 3 health concerns in your communities, and perhaps link that a little bit to your learnings from the documentary that you can apply to your context. So kind of thinking about those 2 bullet points. And we'll go site by site. Sue, I'll have you lead that.
Sure. So let's see. Let's start with Flathead.
Hi. So we, back in December, did our prioritization from our last community needs assessment. So this is very timely for us. And we've had 2 priorities that we selected. One was comprehensive care, and it includes mental health and substance use, which really was the highest need that we saw, and it's kind of been the focus of the Learning Lab for us. But we wanted to destigmatize that behavioral health component, so we're treating it like all other types of comprehensive care, and the same access to care needs that we see in other types of healthcare. Our second priority, and the one that I'm perhaps most excited about is social determinants of health. And the hospitals are on board with looking at some of these other types of needs in our community.
Nice.
Can I ask, what are the specific social determinants you are thinking about?
So our biggest one is housing, and we have a housing as healthcare project going on. Transportation is the other one that comes up a lot in our community. And we won't have that information finalized about what sort of those subtopics are going to be until later on this spring. We have some cool built environment stuff. It's just been hard. Sidewalks, walkability. It's been hard to get it going.
Great. I'm sorry, who was just speaking? What's your name?
I'm Carrie.
Hi, Carrie.
In Flathead County.
I just heard Flathead County. So Carrie,
That's right.
can you tell me who did the prioritization for the community needs assessment? Who was engaged in that?
So the needs assessment has 4 key partners. So we have 2 hospitals in our area, then we're the health department, we're the 3rd partner, and then our local FQHC is the 4th partner. We also invited community members to be involved in the prioritization process. Not very many of them chose to participate in the prioritization part, but we have a lot of community participation in this next step where we're actually making our improvement plan.
Okay, thank you so much, Carrie.
Great. How about Alexis and Avery from New Mexico? I mean, and Heather. Sorry, Alexis and Heather.
Is somebody talking? I can't hear.
So I'm going to let Alexis handle this as we just completed our state needs assessment, and she has probably the expertise around that.
It took me a while to find the unmute to get the cursor to go all the way to that side. Anyway, yeah, so we did just finish our needs assessment and our state health improvement plan, and our top 3 health concerns in that community, not unlike most of our communities, at least as far as I could remember, are obesity, diabetes, and drug overdose deaths. And also access to mental health care. So that's something we'll definitely be bringing to the table. We're actually going on Friday to meet with some folks in the county, and we're running a little bit behind because we're a centralized state. When we started this whole project, we were looking at the whole state, and then we had to kind of identify which county seemed like they would be most enthusiastic about participating in this. So we got our county, we're going there on Friday. They're aware of their data. We'll be bringing them the data and talking about that more, and then just figuring out our next steps. So,
thank you. Alexis, can I ask you, when you say our community, do you have some data on the ethnicity, gender, and age of that particular community?
We do. I don't have it in the top of my brain right now because we have 33 counties, and so it's all kind of, and I'm not looking at it, and I don't want y'all to wait while I try to find it.
No problem. Just wanted to get a feel for the.
Yeah, we do. Actually, we're really fortunate in New Mexico, and we found this out when we were at the face-to-face at the Learning Lab up in Seattle a couple of weeks ago, that we actually have really good data. We have a lot of it. There's really nothing we don't know. Probably the data we most lack in is qualitative data, but we have the expertise where we can do that. You know, once we talk to the county and see what kind of bandwidth we have there. So, yeah, we're really fortunate that way.
Great, thank you.
Great. Nick.
Yeah, so this is Nick in Rock County. We did our community health assessment in 2017. So our priorities that came out of that were obesity, mental health, and oral health. And then another kind of 4th priority area came out, which was health equity. So we decided that health equity would be kind of the frame for all 3 of those priority areas, and we would work on disparities and health equity issues within each of those health topics. So that came from one-on-one conversations with our community members, working with healthcare partners and other nonprofit agencies in the community, and then also we did like a widespread survey, an online survey with our community members, and got about 2,000 responses or something like that. So we tried to pull as much information from our community as possible when we figured out those priorities.
Nick, can I ask you what languages you did the survey in?
We did it in English and Spanish.
And please remind me what state and county you're from.
Rock County, Wisconsin. So we're on the southern border of Wisconsin with Illinois.
And then do you all, when you say you're using health equity as a framework, do you have a definition for health equity in your county?
That's a good question. I'm sure it's in our community health assessment. I'm not going to take the time to find it, and I don't have it on the top of my head. But that's a very good point to kind of make sure that that is a focus when we're talking about that. So we're absolutely sure what we're really trying to work on.
Thank you.
Mm-hmm.
Great. Macon County.
Can you hear me?
Yep.
Yes.
Okay, good. We actually took a look at a couple of different things. We've always partnered in the last 6 years with our hospital to do a community health needs assessment. But last year we also did one that was specifically geared toward maternal child health, which is what we're doing based our design challenge off of. Unfortunately, our community health needs assessment at the hospital did not address social determinants of health. So we're working with an intern who is researching what social determinants of health are, and she's putting together a survey for us that we will be implementing this year. But from our 2016 CHNA, the top 3 most pressing health problems dealt with healthcare. It was affordable insurance, cost of healthcare, and ability to pay for healthcare. Now, on the maternal child health, Cheryl did that research.
And the top 3 on this was from 2017. It was lack of motor vehicle safety, child abuse, neglect, and overweight or obese. Those were the top 3 concerns. So, totally different. Yeah.
Can you repeat that, Cheryl? You said lack of safe roads.
Lack of motor vehicle safety.
Okay.
Child abuse and neglect, and overweight or obesity.
Interesting. And when you all talk about community, like when you were doing the needs assessment, who was the community of interest that you had gathered the data from?
Are you talking about the community health needs assessment with the hospital?
Yeah, sorry.
It's focused on pretty much the county. I know that it probably went a little bit outside the county because the hospital serves more than just Macon County. But it would have been community members within Macon County, which is 15,500 people.
Okay.
Very rural.
Rural, that's what I was looking for. Thank you. Thank you.
Mm-hmm. And Lewis County is the other site, but they had a conference or something, and so they are not on. So we got
through all the sites? That's amazing.
Yeah.
So all of the sites, maybe going back to Flathead, when you were thinking about your community needs assessments through kind of like the lens of the documentary that you saw, is there anything that you learned that you could apply to your own context?
I would say from the documentary and what we're looking at, I'm going to compare their high level of diabetes with individuals, the Latino population that, didn't have access to healthy food, didn't have access to outdoor recreation, playgrounds for their kids. I'm going to take a little bit of a leap here that when we're looking at substance use in particular, we find higher rates in our low socioeconomic groups. And so kind of looking at that similarity there, it's a little bit of a jump, but in my mind, a health condition in relation to socioeconomic status. I would say a second one is those high poverty pockets within our community tend to be some of our most outlying areas. And in our community, we're over 5,000 square miles. Our county, our entire county is the same size as Connecticut. And so we have people who are living at the furthest outreach of that county area, and trying to get to services is next to impossible because our public transportation doesn't run beyond kind of our main center community. So people have difficulties accessing services, which is something that we saw in the documentary as well. The other thing that I think Carrie can speak to with her work on the community health needs assessment is in regards to built environment and again, that lack of playgrounds, whereas here we have a lot of green space. We're in Montana, we have a ton of green space, but walkability or kids biking places is challenging. And people can't get to the green space that we do have because they don't have transportation.
That's a huge issue. Worldwide, and transportation access is becoming a health equity issue. So it's wonderful that did you pick up on, in the documentary, the mobile play center?
I did. I loved the idea that they were bringing the play to the kids, opening up the playground and having structured play to be part of. I thought that was a great concept. And we do have some of our after school programs here that bring the same concept, like the kids all congregate in the gymnasium after school until their parents pick them up like at 5 or whatever, and that they have high school kids or kids from the Parks and Recreation program bring activities to keep the kids busy. They provide a healthy snack. So I loved that idea in the documentary.
I'm good, because I was thinking that could dovetail with some of your concerns too, especially if they're outlying. And if they're not coming to you, you go to them. So, you know, that's the connection to the community. When you know your community needs, instead of forcing the individuals to make a change in their behavior, the agencies can find a way to partner with organizations that can go to them with services. That's always something that we learned. Thank you for that. Alexis and or Heather in New Mexico. But you guys are on mute. I don't hear you.
I'll go first. This is Heather. I think the interesting thing for me is that we are coming up on our New Mexico Public Health Association conference in April, and we have a panel presentation that I'm a part of, and the conversation that's been ongoing for the last couple of days is whether we have community lead public health and that direction that we want to go, or whether we direct communities where public health needs to go. And so what I really enjoyed is just that community perspective, specifically talking about looking at, you know, the parks and the fact that there was no transportation. So how do you get to those parks? And I want to tie that in on the panel with talking about community leading where we need to go, rather than us telling communities where public health is going to go. So.
Thank you, Heather. You know, something that Dr. Bracho has taught me, that it's never an either or. Every time we talk, she always says, or every time I hear her present, she always says it's never either or, that we as experts can bring knowledge to the table, but that we need to do it. In Spanish, they say, instead of thinking of it like a mentoring or hierarchical relationship, you think of it as accompaniment. So there's this whole process of accompanimiento. We're accompanying each other. I apologize for my accent. I'm Persian, but I pretend I can speak a few words of Spanish. So, you know, there's this, the connection that you have of accompaniment. It's a conversation. Should we lead, or should the community lead too? How do we do this together? Because our futures are tied up with one another. So let's, putting our quote unquote best foot forward, and move the needle together. I think I've learned that from Dr. Bracho over the years. Thank you for that. Heather, did you want to contribute more? I saw your mute button go off and on. No, everybody's done. Okay, Nick in Rock County, tell me.
So not kind of one of the top priorities that came up in our community health assessment, but one of the things that we really want to work on in this learning lab is our infant mortality rates. And we have vast disparities in our African-American infant mortality rates. And so one of the things that struck me in the video was that they focused really on making sure that the people with like the health issues that they were working with worked with people who looked like them and also had the same health issues. And for us, that's a challenge because our workforce at the health department isn't very diverse. And so I think we want to make sure that when we're working in our communities that are affected by these disparities, that we promote like maybe a community health worker approach, so that, you know, the people who are in the community are working with the people who are facing the disparities, and not kind of like the health department saying like, oh, you have this health issue and we're here to come in and intervene and make things better for you. But kind of like that approach of working with the community members to improve the circumstances, and not kind of doing unto the community members.
Yeah, and that's so critical. I'm so glad you picked up on the promotora model, the community health worker model. That's been used globally and it's highly impactful. And you are absolutely correct that when people see people that look like them, there's a trust that happens kind of automatically. It's not necessarily that they think they know more or not. It's that there's a trust there. And there's an actual opportunity for opening up a conversation, and it happens faster. So, and if there were linguistic issues, that's even better, right? To have someone that speaks in your language. I wanted to mention something very interesting that a PhD student of mine is currently, she's going to defend her dissertation soon about maternal mortality and infant mortality and health disparities. She's actually studying the difference between maternal and infant mortality with slave descendant African Americans and new African immigrants. And what she noticed when she disaggregated the data is that African immigrants have higher levels of health outcomes in maternal and infant mortality than slave descendants. Isn't that fascinating? Like, she's finding that immigrant women African immigrant women in the United States have health outcomes closer to their white counterparts. Isn't that fascinating? So one of the things that she concluded is that it's not the Blackness that is causing disease and injury in the community. There are systemic issues that we need to address. And it's such good research. I can't wait till she publishes it so I can send it out to everybody. And one of the things that we've realized is when we think of communities, especially if we're thinking ethnic communities, it would be a disservice to our community to say Black, Hispanic, white, Native American, because they're all ethnically, if there's some diversity there, that's really important. We learned that in research I did with a colleague at USC. When you look at tobacco rates, smoking rates across all Asian populations, it looks like smoking rates are declining. When you disaggregate the data, the Korean American population, the rates are going like this. And if we had never disaggregated it, we wouldn't know there was such a need in that specific population. So really thinking through, when I ask the question, who are you talking to? What is that community? Thinking beyond the census data is really important. So for example, I'm forced to put white in the census category, but being Persian American gives me a very different perspective on health behaviors, knowledge, and attitudes based on my own culture and history. I don't self-identify as a European, so I never think of putting white there. I always put other, because I never find myself in the census tract. And I bet you there will be people in your communities that might not align with those tracts. So really getting into the communities and talking to the constituents is really important to understand what is the nuance. Maybe I can have a more culturally appropriate intervention. Just Nick, you inspired me. I apologize I shared so much. But I wanted to go to Macon County, unless Nick, you wanted to contribute more.
No, just that's very helpful information. I think one of the outcomes of this learning lab is we want to have more in-depth conversations with the community members affected to really get a better understanding of what issues they're facing, and not, you know, lumping them as a census statistic or something like that.
Great, thank you. Macon County, I remember the name Jesse.
Yeah, well, this is Mike.
Oh, hi, Mike.
Hi. What's interesting is we each watched the documentary independently and came up with our own perspectives, and we haven't had a chance to discuss those perspectives amongst ourselves yet. But I know that in a few minutes we've been talking, we like the idea about the level playing field when you have diabetics talking to diabetics and low-income people talking to low-income people, more of a peer-to-peer relationship to help support and improve things. I think one of the main things that really struck out to me, other than using community assets, to help make improvements is that you have to have a long-term strategy and a short-term strategy. We work with chronic disease patients to help them improve their quality of life. And we also work with kids on exercise and nutrition, but those efforts aren't coordinated. And if we coordinate those efforts and put those long-term and short-term strategies in play, we probably could have a lot better impact or greater impact in the community.
That's great.
I'm so glad that you talked about short and long-term goals, because I feel like that's that was the heart of Dr. Bracho's message, that it's wrong to do either or. You know, she was very passionate about this, that you can't leave diabetics without access to care, and you can't just focus on there and not think about the structural issues, the environment and the community within which they live, because over the long term, we're not going to ever have enough doctors to sustain the needs of an increasing diabetic population. But if we work on the systemic issues of making sure there's access to walkable, bikeable neighborhoods, park equity, for example, I think it really does a service to the community as a whole. There's one thing that you mentioned, Mr. Mike, that you talked about how it's important with the promotora model to be, to kind of the peer learning model or the health worker model. I want to also mention that our attitude to the community could be that peer. So it's, you know, thinking about how we are in the community, not necessarily separate from it. I feel like sometimes it's an attitude, and especially in communities where you have never had an organization that has developed a community health worker group. In order to be able to approach them first, it's more of an attitude. I would call it a humble posture of learning in that process. So you know that you can be with community members without thinking that you are the expert, you have to know everything, actually approaching with a humble posture of learning. I mean, Dr. Bracho is an MD. She's a medical practitioner, she's a doctor, but you would never know it unless she's talking to you about health. Then you definitely know you're talking to a doctor. But when she approaches the community, it's in the beginning, and I've been in field visits with her where she's a member of the community, and there's no there's no way around her approach to the community. But what she thinks of herself is, I use the knowledge that I have in service to my community. You know what I mean? So and not all the people that live in Santa Ana are from Mexico, even though there's 4 dominant states of Mexico that represent the majority of the residents. You do find Central Americans. So I just wanted to mention that sometimes the attitude, language ability, and the feeling that we are a community and we're in this together goes a long way if you don't find in the beginning health workers that are at the ready to be deployed into the field of action, for example. Any other, so Sarah, Dana, you guys haven't said anything. Do you guys want to say anything?
I just think you're great, and I'm really appreciating your perspective, and I think it's refreshing and needed. So thank you.
Sarah?
Yeah, I agree. I'm one of the project staff members and not from a health department, so that's why I haven't been contributing, but thank you for checking in.
No worries. I want to make sure I haven't forgotten anyone. I think that it's so important for us to kind of think together. I always tell my students 2 heads are better than 1, 3 better than 2, and so forth. So it's all good. I'm wondering if you think anything was missing from your own understanding of the community needs in relation to your prioritization. After you watch this video, like, did you think, oh, we're missing that data? So for example, I think, was it Nick that said that you have, or no, who said that you have really good data, but it's not qualitative data? I thought that was a really interesting point, because my question was, how deep is your data? So, you know, understanding the purview in this kind of context of a bird's eye view is very different than actually walking in the community. So whoever said that, I apologize. I don't know if it was Nick or Alexa.
It was me.
I'm not sure who it was, but I thought that was a really good point. We have really good data. How deep is our data? Do you think is something that's missing in your needs assessment, for example?
Are you asking me to answer?
or comment? I'm
Yeah.
sorry, I wasn't very clear.
I bet we do have stuff that's missing. We're gonna find it. We're gonna know a whole lot more about that on Friday.
Okay.
But that's one of the questions we're gonna be asking for sure. So I just don't know the answer to that question yet.
No problem. Because I think that concept of how deep is our knowledge of the community really matters. So when we do surveys and we do, like we have aggregate statistics, we know the whats. Have you noticed that? We know all the whats, but the whys require us to check in with our community. So really going in and being like, well, why is it like this? So thinking, oh, if I just looked at the data sent to me by the school board, all the kids are getting so many servings of vegetables every day, but what does that actually mean? Why are they gaining weight, for example? I just recently went to a conference where I found out, you all heard of Colorado, and everybody says Colorado has the healthiest population, they're all healthy weight. Well, apparently not so much among children. Apparently childhood obesity is a big problem in Colorado. I would never have guessed that. And so now researchers in the health sector are going out to try to figure out why are children becoming more obese while the adults are actually quite healthy in their weight. Since you all mentioned, for example, obesity, I'm wondering what is missing from your data? Why are your communities stating that obesity is a focus area for them? Anyone want to comment? You guys go. You get to decide who gets to talk. Who mentioned that? I know Alexis and Heather in New Mexico mentioned obesity. Nick mentioned it.
Yeah, I can speak for Rock County. I think that, so part of it is that obesity is just related to a number of other health outcomes. And I think the other thing is that it's just very visible for people. It's easy to put into words that obesity is a health problem because they can see that people are obese and then that there are a lot of health conditions associated with being obese, but they have probably trouble articulating some of the other like social determinants of health that maybe lead to negative health outcomes. So I think across Wisconsin, like obesity comes up as one of the top health priorities when people do community health assessments, just because that's what people latch onto as being a major concern.
Yeah. And isn't it interesting that it's also one of the more stigmatizing conditions, you know? So I would say it's highly related to the mental health. There's a wonderful case study, and I can't remember what county is in. I apologize. I will look for it and send it to you if you're interested. But it was a case study about mental health and how schools as anchor institutions can really be a partner for public health agencies to understand the whys behind mental health issues for children. And in this particular case study I'm thinking of, I think it was in Kentucky. I apologize if I'm incorrect. I can send you the case study, Sue, and you can share it.
Okay.
It was I think it was in Kentucky, so I'll continue to say Kentucky, and then you can correct me when you receive the case study, where when the community health workers, actually from the health department, were going to try to figure out why there was such a mental health crisis, they realized there was an influx of immigrants into these schools, and the immigrants were fleeing violence. And the children were there basically not really dealing with the post-traumatic stress that they were experiencing from their terrible ordeal. This was actually 20 years ago, so it's not a recent case study. And they were dealing with that trauma and continuing to try to cope and learn a new language and be in a new country and trying to deal with their parents' stress at home. And often those children were the main translators for their families, and suddenly they were so responsible. And so what was realized, what there needed to be a support system in place for these children to address the post-traumatic stress that they were having. So on top of all of that, they came from a community that had stigmatized mental health services. And then if you make it even broader, there are communities that don't understand our westernized context of mental health service. Like our American mental health service says, you with an individual talk. Whereas many of the communities that stigmatize mental health are actually very collectivist in nature. And what we don't know how to do is create a community well-being, mental health well-being process. And we really need to talk to the community about their approach to mental health. And so some of that obesity that stems from all of that post-traumatic stress, inability to cope, could be related to drug abuse and alcohol abuse. If you see it in a cultural framework that is more collectivist in nature, you can start to understand that there is that transition to coming to the United States and being in a highly individualistic culture is traumatic in an end of itself. I come from one of those cultures. I'm not trying to make this anecdotal about me, but just know that there is research out there that shows that a collective understanding of mental health is critical to many communities of color. And so spaces that encourage collective well-being is really impactful. Those spaces that allow elders and young people to be together, to connect, impactful. This works so well in Native American communities. It's highly impactful in connecting the young people to their cultural roots, to their lands. Sovereignty issues within the Native American community have been linked to mental health issues now. So, for example, thinking about the kind of disassociation of their historic roots, their lands, and experiencing that, it's not always an obvious thing, but to think, how do we collectively engage a community in well-being, mental health well-being? It shifts the conversation when we think this is more than just about the stigma that I want to go and see a counselor. There's actually a cultural frame that we need to address. So again, talking to the communities, the elders, the places, for example, churches, synagogues, the places where people go to seek well-being becomes really important. Another thing I wanted to mention around the concept of health equity is thinking about the built environment with demographic shifts. We noticed that here in Orange County, we were doing some analysis of parks and physical activity. And we realized that the Parks Department was encouraging the parks to be used in a way that they were used in the 1950s. Picnics, baseball, and apple pie. And that's wonderful. I love all those things. But the community that had moved in was eating tacos, enchiladas, and connecting and having mental health restoration, and then playing soccer and volleyball. So they were, according to the parks director, destroying the baseball field. And according to our observations, we were saying, well, they don't want to play baseball, they want to play soccer. So can you convert the baseball field to a soccer field? No, this is a baseball field. And we're like, but the community is actually showing you very clearly that they want a soccer field. Is there a way to design the baseball field that can be flexible so that you don't feel like you have to constantly improve the baseball field? So there's a conversation that needs to happen with the community that's moved in, because communities don't necessarily stay the same over time. So for example, young people today might want to skateboard. We've seen that in Santa Ana. That when we talk about active transportation and we say biking, walking, there's a whole group of people that feel left out. So an 8-year-old kid came up to me in my walking and biking advocacy and said, Dr. Mo, why aren't you talking about skateboarders? And he said, you need wheel equity. Get it? Wheel equity. And then I thought, he's so right. I mean, when we say walking and biking, we assume wheelchair use, skateboarding, but we never make it visible. So how do we make all of it visible so that there is that wheel equity? So really thinking, who am I missing? How deep is my understanding and my knowledge? Who is not responding to our community needs assessment? And not to necessarily blame them for not choosing to come to a meeting, but thinking, how do we get out there? I'll give you an example from Westminster it's a city in Orange County, which has one of the highest populations of Vietnamese and Cambodian Americans outside of Vietnam and Cambodia. Every time the planning department had any kind of public meeting, no one would show up. So they just put in the meeting notes that the community chose not to come. There was a student in the planning department here at UCI who was Vietnamese, and she said, I want to go out to the community and ask them why they're not coming. No one had ever done that. After 20 years, by the way. So this young woman decided to go into the community and ask, why aren't you coming to meetings? Now, mind you, she was born here, she was second generation. And what she learned was extremely insightful and important for the city. What she learned is that there's still collective trauma from Vietnam.
Mm-hmm.
And there was a distrust of public agencies and public meetings, which the elders were used to being ostracized at, threatened at, and there was violence resulting in those. Even if you had been here for 30 years, that collective intergenerational trauma was still impacting their ability to go to a meeting. So when this young planning student told the city manager, look, if you really want to engage the community, you have to go to them.
Mm-hmm.
Business as usual is not going to work here. And so the city manager, very open-minded, actually was like, oh my gosh, that's what we need to do. So rather than think of it as a checkbox, we invited people to a meeting, they didn't come. I wonder if we could frame it as thinking about how can we engage the community. Maybe we need to go out there. Maybe nobody's ever come. Maybe they don't trust us yet, right? So it's like thinking about that and then wondering what are those organizations? So I'm going to the question of, I'll come back to the bullet on top, but do you currently partner with a community-based organization that champions health in the communities that you are seeking to engage? Why or why not? And who could you partner with? And I'm wondering if you've had those conversations and thinking about, wow, there is this community organization we really haven't connected to, but we really need to connect to, or to maybe include them as partners for community health workers, for example. Anybody have thoughts on that? Maybe we'll go to Macon County first. Maybe not, Mr. Michael.
I'm sorry, specifically, what are you asking again, the question?
Do you have community organizations that are health champions in your community that you partner with? And if you don't, have you had thoughts about how to engage with community-based organizations or nonprofits? I guess we call them nonprofits in the United States.
Well, we are right now, actually, because we are partnering with the YMCA, which is pretty big within our community, and in more than one way. We have a nutritionist who worked with the program director here to put in nutrition and exercise class. It was a 6-week class. And then we're also partnering in our design challenge to try to combat childhood obesity. We have worked also with some faith-based throughout the community with outreach clinics and then different kind of city governments too. We partner with them not only for public health issues, but also for emergency preparedness issues. I'm sure there are others out there that we haven't tapped into yet. But I think as we see where needs arise, it just sort of leads us in that direction.
Mm-hmm.
And I'm so delighted that you mentioned that the community that you are engaged with is a rural community. Here's what I know. I grew up in a rural community. Here's what I know. Nobody just has one hat. Everybody wears a million hats because there's not enough people. And so often, depending on what hat you're wearing, right? So I was a tutor and I was a reporter and I was, I worked in a plumbing shop growing up. And I was a volunteer caretaker, like childcare at our annual fair, a kind of agricultural fair every year. So I get rural communities actually have a very unique situation, I think, where it's spread out, definitely, but also people wear multiple hats. So you're often engaging in different contexts with the same people. And the champions are there because they need to be there. I'm wondering, what do you think, Mike, of my assessment?
I think it's spot on because that's people who have done things or in positions to do things seems to be the ones you go to all the time. Yeah. Because they're the ones that have the networks and they're within their communities. So I agree with you.
And I think in that context, the concept that I mentioned of accompaniment is really critical. And having I would say even older youth accompany younger youth in this process is really impactful, because I know there's studies about this actually that look at youth empowerment programs that connect, like it's kind of like the Boys and Girls Club. I guess YMCA does that in a way to kind of link the older youth with the younger youth, but it's so impactful. And again, anecdotally from myself growing up as a young person in a small remote town in Washington State, in Bellingham, Washington. Now it's a lot more urbanized. Back then, when I lived there in the 1800s, it was a little bit more rural. Just seeing who's paying attention. But really having that connection to the older youth, you know, was so impactful for me, because you sometimes as a young person or as a kid, you feel lost in those communities, because especially me, I didn't know what I wanted to do with myself, but I knew that I didn't see the example around me all the time, you know? And so I needed that mentoring to know that I could do something else. Maybe that wasn't even discussed yet or discovered yet. And I had this amazing young, like he was maybe 5 years older than me, he became like my big brother, who would constantly say, tutor younger kids, and he would take me along with him, and then I would tutor even younger kids. It got me involved and engaged in the community in ways that I didn't think were possible. So that connection of that, especially in rural communities, between the older youth and the junior youth are really impactful. Anyone else thinking about community-based organizations or nonprofits that champion health in the community? And maybe you have them, but you're not working with them. And I'm wondering if you can talk about any challenges that you might have in this regard.
So this is Flathead County. And one of the agencies that we're just starting to work more closely with is our library, in part because they have branches all across, they're geographically diverse. The other piece that was really impactful here is the libraries come with this philosophy of abundance, which just really does it for me. And so for so many low-income families, there's this idea that if the government's going to be programming, then they should just be happy with whatever they get. Like they should get, you know, they should just be happy. And the library's philosophy around stuff should be nice, programming should be very high quality. You know, we should be providing a service and we should treat it like we're providing a service to a customer, instead of having this attitude around like, you should be grateful we're even showing up. And I think it's been really beneficial for us as we're thinking about how do we program, and how, when we're asking for feedback on our health work, how do we ask for it in a way that also conveys that same philosophy of valuing the person on the other side of the table. It's a work in progress. And someday we want to do like a bookmobile / nurse in a van, like driving around. That's the dream.
That's amazing. Do you work with non-English speaking populations?
So we do. So we're maybe 95% white, non-Hispanic county. We have a lot of undocumented workers because we're a tourist area. So probably our most common language is actually Vietnamese. But we also have a lot of like not easy languages to get translated materials in. So we'll have some Spanish speakers, but then, you know, it'll also be some different Chinese dialects. And we have a translation and an interpretation service, but we don't have employees who speak those languages, and we don't have anyone at the library. And some of those, that undocumented transient worker population has been the hardest to reach, and they don't trust us, and I don't blame them, but we haven't had a lot of success, especially because it's such a small proportion.
It's so hard to address. We have that issue here. We also, what we found recently, people are becoming more and more afraid to seek out any kind of assistance programs. So we've noticed our food banks, for example, the food is going to waste because people are scared to come to an agency because they're afraid that the federal agents are gonna come and deport them, even if they have green cards. Like, they're really scared. So we're trying to figure that out too. And I think it's an ongoing conversation. We have some organizations here that are in touch with that particular community. So it's easier for us. It's harder to do if you don't have an organization that connects to that community. So where do you reach out to? I love this idea of the library. In fact, I just read a case study about putting social workers in libraries.
Mm-hmm.
And that becomes a very impactful place because libraries are seen as safe spaces by the community.
Mm-hmm.
Thank you for sharing.
I'm sorry if I don't know if I interrupted, but I was at an event in Philadelphia. It was actually an innovation lab event, and there were people there from the library, and they're doing some incredible work, and they actually have nurses stationed at the library. They're doing all kinds of like economic and workforce development. So, you know, when you think about the populations, right, like a lot of them, that's where they go, you know, particularly if it's homeless or anyway. So I think it's a great point.
Yeah, excellent. Any other thoughts? I'll go to another question, don't worry. Oh, did somebody, yes? Okay, why don't we go to the question about clinical care. What does it mean for you, for your community? If I were to ask you that you have to, when you do your plans, to think about both the short-term and long-term needs of your communities, what does that mean to you? How is that, will that shift the way you're going to plan and program and prioritize? What does that mean? And can you do it? What does it mean? Maybe we go to New Mexico. Alexis, Heather?
Unfortunately, with a lot of these, we really aren't going to know anything until Friday because we're running a little behind. So,
no problem. Alexis, I want to challenge you to think about those priorities, short and long term.
Yeah.
Yeah, I think that might be impactful for you. But what do I know? I'm sorry, we're just talking.
No, that's good. I mean, I'm definitely taking notes and going to be integrating this into our agenda for Friday. So
thank you. Wonderful.
I appreciate it.
Yeah. Nick.
Yeah. This is a great question for us because I think kind of what precipitated our move away from direct service was we saw a bunch of partners in our community that were already providing the same services that we were providing. And so our work related to clinical care now is shifting away from providing the services and now making sure that people get access to those services in our community, which is a lot more challenging because we have to establish relationships with our healthcare partners to make sure that they can change their processes to, make sure that they're at capacity and they're operating in the communities that are needing those services. So it's a lot more like relationship building on that end. And then we're still kind of struggling what exactly we can do as a public health agency to promote population health. I think we're looking at those policy and systems change, but what exactly those changes should be or what they should look like, we haven't really figured that out. And we're on that journey, I think, right now.
And I think that's the beauty of engaging with community, that you don't have to feel responsible to figure it out on your own. Mm-hmm. Especially if you have an open relationship with the board of directors of a hospital. And if there's some type of community arm in that hospital, so many hospital networks are moving towards a social determinants of health model. For example, the American Heart Association has annual grants to address the social determinants of heart health and brain health, which include dealing with obesity, for example. So they give $25,000, $30,000 grants, and you can even get a grant to think about it, to have community engagement, to think about what are those social determinants, those systemic changes, structural changes that you can make. I would say look for these organizations that have traditionally been embedded in the biomedical paradigm, but are now shifting to understand that you cannot have sustainable health outcomes over time by just increasing clinical care. I think of clinical care as a short-term need. We need to make sure that people have access to treatment. It's critical. We don't want people to die. But at the same time, we can't just jump into the river and save the babies. We have to go upstream to figure out why they're falling into the river. And so as we leave our doctors on the downstream side to make sure that none of those babies die, drown, or go over the waterfall, we have to send a public health workforce upstream and work with our transportation planners and our bridge builders and everyone that's trying to cross the bridge to figure out what's happening. Why are you falling into the river? So really thinking about, for me, short and long term is thinking about the downstream clinical approaches in the short term. What are those needs? How do we need to address this? And over the long term, how do we prevent disease and injury in the first place? I always tell my students, if we did our job right in public health, we wouldn't need doctors and pharmaceuticals. And it's a challenge to them, right? Because we know that we will always need clinical care. That is something that we need in the health field, but that's a great place to start in our needs discussions, but it's a terrible place to stop, because then we're constantly trying to take water out of that boat instead of trying to figure out why that hole is in our boat in the first place. I'm sorry I keep interjecting. I don't mean to. I get excited. It's your fault because you guys get excited. Thank you, Nick. Let's go to Macon County again.
What's interesting in Macon County, if you talk about clinical care, Macon, the city of Macon is a city of 5,500 people, but yet we have a critical access hospital, an FQHC, an urgent care, and a rural health clinic.
Jeez.
As well as some private physicians' offices. We're heavy with healthcare until you get to the outlying communities, which may have a nurse practitioner or even an urgent care, but not much else. So in that respect, we as a public health organization don't do a lot or any clinical care. But our focus though is still sort of reactive. And that's why we're trying to go with the upstream notion, working on the social determinants of health for prevention. So that way there's more of a concerted effort to tie those two together with clinical care. I think it can be done. And I think we talked about earlier, finding the right community partners to help with that. But I also then too like the whole idea in the documentary about finding out what our community assets are and tapping into them.
Mm-hmm.
That's so impactful. And you mentioned, your colleague mentioned the lack of safe roads conditions for mobility, child abuse, neglect, and overweight. And I'm wondering if you've had a chance to really think about how do we approach this from an upstream perspective?
Mm-hmm.
Well, I know when you talk about transportation, one of the things we started doing last year is in 5 of the bigger towns within the community, we started doing outreach clinics. So that way we could take preventative health measures, mainly a little bit of education, but immunizations and that out into the community so that they didn't have to come into Macon to actually get that. Childhood obesity is one thing that we are currently working on right now. We just, I don't think, have gotten to a point where we determine what the root causes of that are within our community. So we have a little bit of ways to go before we can actually put together any type of initiatives to do that.
Mm-hmm.
Thank you. I just noticed there's a whole bunch of things happening in chat. Am I supposed to look at something?
I just said we have 5 minutes.
Oh, sorry. Thank you, Sue. I'm so sorry.
No, don't be sorry. I'm like the Dana calls me the wizard. So I'm like from behind, right? Like.
Thank you, wizard. Well, let's go to Flathead before we end this part of the conversation. Flathead?
Sure. So Carrie had to step out for a second. So I would say for us really looking at this project, which is addressing mental health, substance use needs, population health needs in our community, I feel like we're really looking at who are the partners out there. We're working closely with those community partners to find out where are our gaps, where are our overlaps, and we may identify that there are certain areas that we can't pull out of direct clinical services because nobody else offers them. But we don't ever want to be in competition with abundance of services. That would be an area we would obviously take a step back from and provide more population health upstream services versus that direct clinical service. So, you know, things we're really looking at and working on are, we're working with community partners to make sure that our clinical settings within the community are providing medication-assisted treatment for substance use. We're looking to expand to provide better screening brief intervention, referrals to treatments as a public health component to support our community with training and infrastructure to make sure that that screening process and early intervention can take place. So I think we're trying to look at both ends to put more of our eggs in the prevention upstream basket, but know that there may be some areas that we have to support the clinical services.
Yeah, totally. And I feel like clinical care is partner with the preventative care. Like I've never felt that we could separate them necessarily. And I feel like there's a wonderful medical doctor at Harvard, Dr. Paul Farmer, you may have heard of him, who talks about the doctors, healthcare workers are natural advocates for the community. And that, you know, if we have that connection and close collaboration, we can help the doctors by preventing disease upstream so they can deal with the most serious cases and not the ones that come in because of a preventable condition. So I feel like that's really important. Just for the sake of time, thank you for all of your inputs. I really do hope that your learning continues from Dr. Bracho and that documentary. I wanted to give you two examples of the importance of community engagement and kind of think about lessons learned from a partnership. Some of you may have heard of the PITCH project, the Partnerships to Improve Community Health. It was a CDC grant that followed on the HEAL project, the Healthy Eating Active Living grants that were given out. It was from 2014 to 2017. It was a 3-year project. I was one of the evaluators for the project in Orange County, which was aiming to prevent chronic disease through policy systems and environmental changes, or what we all call PSE, in underserved communities. And here in Orange County, which has 34 cities and usually is stigmatized as a wealthy community, I say stigmatized on purpose, because I think people don't understand there's a lot of health disparities between cities in Orange County and actually within cities as well. So Anaheim, Garden Grove, and Santa Ana tend to be in central North Orange County, which suffers from the highest rates of disease and health disparities. And one of the things that we did is to work on environmental changes. So in Santa Ana, we worked on improving road conditions for bikes and pedestrians in the downtown corridor. And then in Anaheim and Garden Grove, we worked on park improvements to enhance the physical space to be able to test whether or not that had an impact on increasing physical activity. The good news is in our park studies, we realized that adding a fitness zone, you know, the exercise equipment, adding a fitness zone actually increased activity levels in a park. What we also realized were that our methods of evaluation were not able to actually capture some of the equity tools that we were hoping for. What I mean by that is, I talked about it earlier, what happens when the population shifts in a neighborhood and the parks are not being used in the capacity that were built for in the first place? Do we fix the park business as usual, or do we engage with the community that's moved in? And that was not something we could capture with the tool that the CDC asked us to use. So we did much more in-depth kind of participant observations in that process. And we also engaged with conversations through interviews with the communities to ask what they needed. And then provided that, we will provide it. I haven't given a full report yet to the parks, but be able to provide that so that they know that, yes, it's wonderful to put a fitness zone in a park. It increases physical activity levels. But are you addressing health equity issues? And we found in that context, we weren't. So we had to do additional studies to be able to bring that up. And then in Santa Ana, we realized that just creating the space for bikes is not necessarily going to shoot up biking and walking in a community. There's also systems change, cultural change that needs to happen in a car-centric community that is used to thinking for speed and convenience rather than taking the time to take a walk or a bike ride. So we realized that those cultural determinants of active transportation are just as important as those physical changes. So we realized physical change is a good place to start, but we can't stop there either. We have to also think about education in that context as we go forward. In the OC pitch, working with communities, we know is not easy. It's not easy at all. You need access points. But see if you can reach out. There has to be some nonprofits. There might be some gatekeepers and key informants. There might be an elder, a grandmother, a grandfather, an elder, a youth who's really impactful in the community. You need to look for those champions of health. Maybe there's a program you can develop for champion moms or champion youth that can really help get that peer-to-peer connection. We in Orange County, in the Pitch Project here, we had 10 partners that included agency and nonprofits. And one of the more impactful things that we learned is that the health sector can't do this by themselves. So when you think about, for example, transportation, how engaged are you with the transportation sector? How engaged are you with those engineers and public works staff members? At that level, you need to engage in community as well. Who in the community, in the political space, can be your champion? In Santa Ana, without the council member who was really a champion, we had one council member who was really a champion for active transportation, we wouldn't have been able to do this project. So remembering that community is more than the residents. And in order to do a holistic project, you have to reach out to those entities as well. Other agencies that are not health sector, as well as thinking about who are my political champions that could really help me take the upstream work forward. Work with an anchor institution. I mean, I think some of you have connections to a university, but if there's a college, a community college, a tribal college, work with those anchor institutions to provide you an access point or to connect. And it's a wonderful space to be able to connect to a group of residents and community members that you might not have been able to reach out to before. And finally, I would just say from that process, we really learned the humble posture of learning. The learning that I wanted to give you from the diabetes in African-American communities was that my research assistant a couple of years ago really wanted to understand why African-American women who are over 50 years old suffered from higher rates of diabetes than their white counterparts. And to make a long story short, rather than having a conversation, what she found was really surprising to us. She actually found the access point for this particular community in the churches in this specific neighborhood. And she went to those churches, she talked to the pastor and the community kind of liaison and asked if she could do some focus group studies with the women, who, by the way, had most of the women in those churches were, had already received a type 2 diabetes diagnosis. And what she found in talking to these women were that most of them were not being compliant. You might all have some assumptions why, but when she delved in a little deeper, what we realized, and I work on a diversity in medicine program as well, and what we realized was there was a fatalism among this particular community that made the women think this was punishment from God. And without addressing why they were being punished by God, they didn't think they deserved their medication. It was because my research assistant was African-American. It was because my research assistant's grandmother attended this church that she had access to such level of in-depth. Remember I said, how deep is your knowledge? That depth of information. The trust that she could develop had created an opportunity where the women could actually share that with her. And when she came back and we were talking about this, we were saying, how many studies and interventions have been done on African-American women over 50 with type 2 diabetes that address this issue of fatalism? And so we would never have known that had she not been the one to do this research. So just to think, that's what I kind of want you to take away from that question I asked about how deep is your data? And how much can we cater our programs to make sure that we're addressing the root causes of disease and injury. So by way of wrapping up, you know this, preventing disease in the population really requires us to address multiple risk factors. So these are rooted in social determinants of health and they include the non-health sector. I've actually evolved my thinking of social determinants of health to thinking about structural determinants of health, because that gives me the space to explore concepts such as fatalism in diabetes prevention. And so really thinking about what are those structures that are preventing, whether they're tangible or not, that are preventing healthy choices. And then public health has to partner with communities and non-health sectors in order to create these successful programs and transitions away from clinical to prevention. These transitions, we have to know, and it takes a lot of work, how to go to a non-health agency and say, we need to partner on something. It takes a long time. We've been working on this forever in Orange County. And we're actually exploring the idea of having a health and all policies coordinator at the county level for the health department. Mm-hmm. We have a social determinants of health committee, which is a voluntary committee. I sit on that committee here in Orange County, which explores with different agencies. We have education staff, we have anchor institutions such as universities represented there. And I feel like that's really impactful for us, that there's a focus in our community to work on prevention. Okay, I'm sorry, I've taken way too much time, but I'm supposed to do this now. Thank you so much for your attention. Sue, I'm so sorry.
No, it's okay. It's gone over, but I feel like it's important. And what I want to say is that you basically, I think through your many stories, have demonstrated like theory U, like you're coming together, you think it's X, right? You think it's diabetes, but as you're going out and learning, getting that systems perspective, you've given so many stories about it isn't necessarily, yes, it's diabetes, but there's a reason. And I think the message for all of you, right, is how you actually go out and get those stories, and then what are you going to do with the information, right? Because as you're trying to figure out how to transition from X to Y, because those stories are going to tell you what's really needed in the community. So I think, when we were together a couple of weeks ago and we were having that data discussion, I mean, this is where, right, there's the prevalence and the incidence, but then there's this other kind of voice data opportunities that I think are going to be really impactful. So, I mean, Dana was sending me a note. She's like, these are all theory U stories. I'm like, absolutely, right? So thank you. So
no problem. You can pay me later. Just kidding.
Okay. And I know we're a little over time, but I don't know, this is such a great opportunity. Any reflections, thoughts, any ahas? I'd just like to hear from y'all before we go on and do some other fun, exciting things. So Nick, anything you want to share?
Yeah, I would just say this is very reaffirming for us because we're on kind of this journey away from providing the clinical services and directly kind of addressing some maternal health issues. And I think the last story kind of resonates with me, where I think the more that we dig into the issues, we'll find that some of the underlying causes are not like people just don't want to go to the doctor. It's going to be more complicated than that. So it's nice to hear that, we're on the right track, and hopefully we'll get those stories and be able to make some changes in the community.
Great. Thanks, Nick. Flathead?
I don't know that there's anything that we need to add. We were just commenting that this really just reiterates that need to look for root cause. I had participated in a program this past year that I did a project in regards to substance use, and it's really just making me dig that project back out in my mind of poverty and what do we do to address that root cause that's leading people to have substance use issues. So I think it's just reaffirming.
Great.
And we agree with kind of what Nick said. It's kind of helping us continue on this path.
Great. Thanks. Mike?
I think one of the things that we really like here is that this whole process has given us a different perspective on looking outside our normal box at different assets within the community and different organizations to partner with. Because, one thing we think about here is sustainability. How do we put something together that's sustainable? And I want to say that probably is a key. Sustainability is to tap into the community itself.
Yeah, absolutely. Great point. Thanks, Mike. Alexis?
I just wanted to say thank you. It was really good to hear all of this, and I'm looking forward to I now have this nice encapsulated set of things and ideas to bring to the county on Friday. And that was what I was going to work on, sort of digging out of my brain and writing down today. And you basically just did that for me. So I appreciate it. And yeah, I'm looking forward to seeing what they have to say.
Good. And Alexis, if you need any support thinking through, like between now and Friday, let me know.
Thank you.
So, yeah. Great. Sarah or Dana, any comments?
Just a lot of gratitude. Thank
Yeah.
you so much for all those stories and helping us see to always go deeper.
Mm-hmm. Yeah. Good.
Yeah, thank you.
Very good. Thank you, thank you, thank you. You guys have an amazing, and you guys have an amazing day, rest of your day.
Bye, everybody. Thank you. Nice to meet you.
Bye.
Bye.
Bye. Thank you.
Bye.